20.
يسعد مساكم جميعا. اهلا وسهلا بالحضور الكرام. دكتور رائد عقل راح يقدم لنا هلا Cardiogenic shock beyond the guidelines. تفضل دكتور رائد.
السلام عليكم، يعطيكم العافية جميعا. أول شيء نرحب بجميع الزملاء الضيوف من الخارج ومن الداخل، مبسوطين نكون معكم اليوم. أنا صراحة فكرت الدكتور محمود راح يحكي more in length about culprit shock، بس I have a case of a shock that we will discuss and I called it beyond the guidelines. I'll tell you why. I have no disclosures. Our patient is a 40-year-old male patient, smoker, hypertensive, positive family history, presented with slightly more than a day of on and off retrosternal chest pain associated with diaphoresis, nausea, and dizziness. He was just maintained on blood pressure medication and his labs were significant for high troponins. His physical exam showing S3 gallop with crackles, blood pressure was around 85/50, and he was having active chest pain. His EKG, as you can tell, showing an inferior wall MI. A few minutes later, EKG was repeated. It's an info posture and some changes in the lateral leads. We took him emergently to the cath lab. We'd appreciate in the LAO caudal that there is a significant LAD disease in the prox mid. You see it more clearly in the RAO caudal, showing a 90-95% mid LAD. Some circ obtuse marginal disease with some ectasia. And that's the culprit. As all of you, it's a simple case, simple angioplasty case. RCA angioplasty was performed, stented, for people who talked about stent booster, we use the stent boost to optimize our stent implantation, and we'll show you the final results for the sake of time. That's the RCA ectatic slightly with good final results. So after the procedure is being done, the patient was still having chest pain. His mean systolic blood pressure maintained on the 60 to 70 millimeter of mercury for a systolic 80 to 90, and he was still having evidence of chest pain. And the question based on the guidelines, would you do the non-culprit artery? Here the RCA was the culprit. Would you do the LAD? The LAD was having 90 to 95%. So as Dr. Mahmoud alluded to, in culprit shock trial, they took those patients, and it is in the guidelines now that you need to do the culprit, stop, and stage your patient. And I will add to what Dr. Mahmoud said, that for angioplasty of non-culprit arteries, it is either during the index acute MI PCI or during the index hospitalization pre-discharge or staged after. All of them are options you have. So in this patient, and again for the sake of time, I chose to go for the LAD at the same session. So we appreciate the proximate LAD. Again, another type, regular standard stenting. Using the stent boost again to optimize the stent, and we'll get you to the final results. So we accept there was a small gel diagonal. Okay. Final results. And that's without a wire. Okay, so the patient did really well with no more further chest pain, stable hemodynamics. His ejection fraction pre-discharge was 45 to 50 with inferior wall akinesis and mild anterior wall hypokinesis with a mild MR. And this is the EKG at discharge. So if you look at the guidelines, and that's the ASC guidelines, saying that during revascularization procedure in patients with shock, you only do the culprit, leave the patient alone to get more comfortable, and you can do him whether the same hospitalization or you staged him. That's class 1. And it is translated now at the bottom, where if you do it routinely that you open the non-infarct related artery, it is class 3, while if you look at 2B, which is the middle section, that if your patient is stable, and Dr. Mahmoud has mentioned that, if your patient is stable with STEMI, your chances of opening the non-culprit artery will reach the 2B classification. Now, the ACC and AHA are a little bit more leaning toward more angioplasty done at the same session. So that is being reflected in their consensus guidelines, saying that you can open the non-culprit arteries in the same session. What Dr. Mahmoud failed to show you that in the culprit shock MI trial, there was an exclusion criteria, and one of them is the one before the last. If the shock, shock should be onset more than 12 hours, it's an exclusion criteria, which means that if your patient come in late, that patient is not part of the culprit shock recommendation. So our patient was more than 24 hours. There was lots of criticism for the culprit shock trial, that many patients were with CTO were included in the arm of complete revascularization. And just to give you a summary, the culprit shock said, if you do the non-culprit arteries the same session, your patient might die more and they might have more renal failure. But they excluded all patients who went to bypass urgently, and there were around 25% who had CTOs and you needed to spend more time and die opening them. What's beyond the guidelines? And that's what I've been practicing myself. The infarct-related artery duration is the essence. If the patient is having a STEMI cardiogenic shock with symptom duration more than 12 to 24 hours, then critical non-infarct-related artery lesion needs to be addressed. Why? Because we have the benefit now that PCI of those arteries closed for more than 24 hours is usually less beneficial in terms of prognosis. My point is persistence of unstable hemodynamics and chest pain, infarct-related artery is being closed more than 24 hours. You should consider immediate PCI of non-infarct-related arteries. And finally, if the infarct-related artery is less than 6 hours, then we don't need to go beyond the guidelines. Thank you.
Thank you, Dr. Raed. We'll continue we'll take the question at the end of the session, inshallah. Would like to invite Dr. Nizar Shakhshir, our colleague from Palestine, to get us through the STEMI in the 20s.
Thank you for the invitation. It's always a pleasure to be here in Amman with you. Okay. We're presenting just an extreme case of fairly usual post-pregnancy chest pains. This is a 22-year-old lady who came to us to the clinic, to the hospital, emergency room, 1 week postpartum. This was her second pregnancy. The first pregnancy went well. She had no significant past medical history. She had a low weight. She was a tiny lady, and she weighed only 45 kilograms. She presented with 4 days history of on and off chest pains. She's been to the emergency room, the governmental hospital, and she's been reassured. Then in her last visit to the emergency room, she was noted to have a minimal ST elevation in the anterior leads and a mild raised troponin at 1.25. Thus, she was referred for coronary angiography. We transferred to the cath lab. This is the right coronary artery shots, which were unremarkable. And then when we moved to the left system, you can appreciate that the left circumflex looks fine. And then you're wondering, what is the LAD and diagonal, which were not very clear. You could see them here filling at the apex with fairly akinetic, hypokinetic apex. We've done further shots to ascertain that there is no apparent vessels, which you could see there is none. And this is a lateral view just to try to understand the anatomy a little bit more to see where is the LAD. We've decided to go for the intervention. Here you could appreciate a wire in the diagonal, and we've done some ballooning to restore some flow before going in with another wire into the LAD, trying to do some ballooning to try to restore flow. Here you could appreciate the dissection, which is an extensive dissection throughout the LAD with thrombus formation. We've done multiple ballooning. We've given her glycoprotein 2B3A inhibitor according to her body weight, in addition to heparin infusion. And at one stage we were thinking, do we stop here? We've managed to restore flow. Can I just get this last slide to do again? باشا بس آخر واحدة تمشينا إياها مرة تانية. We took our wires out and we thought, do we leave it like this? In addition to the ugly dissection, you could appreciate that in the proximal LAD, we thought there is a big hematoma which is compressing the LAD. And we thought very uncomfortable leaving this the way it is. So we thought we need to secure the proximal and mid LAD. And this is what we did. Right. So we rewired the vessels. And then we decided to send the proximal LAD, which is fairly an osteal lesion, or like the hematoma was extended to the ostium, but we managed to put a stent in there, and then to cover the severe dissection in the mid vessel, we've implanted an overlapping stent. The distal dissection, we thought this is an area where in the future she might require a lima or something like that, so we opted to leave that. And the plan was that we'll bring her back in to have an IVUS about a week later, just to understand what's happening with our stents and whether we need any further intervention. This was done a week later, and here you can appreciate this is the IVUS of the LAD itself. And you can still see the hematoma in the back here at 11 o'clock. Once you go into the stented area, you can see that the stent is well opposed. Although angiographically she had the ostium of the left circ, that she had an aneurysmal area there, but the decision was made at the time to leave her on medical management without doing any further intervention. So in general, this is an extreme case of a spontaneous artery dissection post-intervention, post-delivery for a fairly healthy young woman. And we just thought sharing this experience with you, that it's not the usual case that we normally get. Thank you. I was courtesy of Dr. Yunus. She was transferred to Najah.
I'd like to call again Dr. Raed Aqel to speak about intra-aortic balloon pump, a little hope in a situation of hopeless.
يعطيكم العافية. السلام عليكم مرة ثانية. برضو رح نحكي اليوم beyond the guidelines in this our next case. دائما بحب أحكي الشغلة هي مش نكتة. بس أنا I practice 3 days in Palestine و 4 days here in Jordan. بس لاحظت بالفترة الأخيرة في الأردن إنه الفلوس اللي بتنحط في البنك عندي بتزيد. فانبسطت أكيد زي أي واحد يعني، بس ما عرفتش ليش بالرغم إنه الفوليوم تبعي عادي يعني. فاللي اكتشفته في النهاية إنه شركات التأمين بتحط فلوس الدكتور رائد عوايشة RA، هو بيحط اسمه دائما في حسابي أنا. فتمنيت إنه رائد موجود بس مش موجود، بس فعلا أنا مبسوط، بس هو بقدرش يحكي ولا كلمة لأني بعرف الراتب تبعه هلا. فهاي لاحظتها وأنا بالأردن إنه راتبي زاد. thank you. We'll move to our case. I have no disclosures. Our index case is a 56-year-old male. He has strong positive family history for CAD, presented with progressive chest pain for 48 hours, suddenly collapsed at home. EMT was called, 20 minutes of amateur CPR done by standby family member, followed by CPR and ACLS, 3 cycles, got 2 360 joules DC shock, secondary to ventricular fibrillation. 50 minutes later, reached the emergency room, intubated at the scene, and had another attack of VFib arrest requiring 1 DC shock. His blood pressure was 80/60. His EKG was malignant. He was done by one of my colleagues, a senior colleague. That's the RCA, middle 70% lesion. You can appreciate that. And as all of you expect, the LAD is occluded. Had 1 ventricular fibrillation arrest at the beginning with the case, then cath resumed, immediate angioplasty. Regaining some flow, and then followed by stenting. Patient was on inotropes. His blood pressure improved a little. And these are the final pictures. There was middle LAD disease, you can appreciate that. And also distal to the stent, there was some hazy lesion. But the patient again was dying, so multiple DC shocks. So it was felt at that point of time, this is enough. He's back, his hemodynamics improved slightly on inotropes, and he was sent to the CCU. So his hospital course, I rounded on him 3 days later. On the 3rd day, he was still in cardiogenic shock on maximum inotropes, vasopressin, norepinephrine, and dopamine alternating sometimes with dobutamine, but there was persistence of hypertension. His ejection fraction by echo was 10%, severe global hypokinesis, akinetic anterior, lateral, and apical walls, moderate MR, and pulmonary artery pressure 46 millimeter of mercury. He had worsening kidney function, liver function, approaching the need for renal replacement therapy and dialysis, with worsening respiratory parameters. He was really a hopeless case. So I decided, since I rounded on him, that there might be a role here to do something. Took him to the cath lab with the plan of opening the right coronary artery and putting a balloon pump, because nothing more to lose. That's his RCA. You can appreciate the middle significant disease. Stent was placed, optimized, and that's the artery after with myocardial blush. I looked at the LAD at the same session, and the LAD was open, still with that middle disease. You can appreciate distal to the stent, and at that diagonal bifurcation, There was also some disease, but since it was open, the patient is in cardiogenic shock. No more diet, was limited amount of diet used. I placed the balloon pump without any data, just feeling that this was the correct thing to do. His hospital course, he did well for a few days with improved hemodynamics. His ejection fraction improved to 30%. Normalized kidney and liver function test, extubated successfully, and he started mobilizing when on the 5th day he has chest pain, and that's his EKG. He had Q waves before in the anterior leads, but no more, now more ST elevation with active chest pain. Taking him to the cath lab again. I still have 1 minute. Okay. So the LAD, as you expect, was thrombosed. Again, we cleaned the artery, ballooned it, and then we placed a stent in the middle uncovered part, and another stent at the diagonal bifurcation. Okay, and that is our final results. These are the final results. So acceptable in the results of the LAD. In fact, did it twice, one original and the second one. His hospital course, he left home on the 9th day. He was lucky. His ejection fraction improved to 35 to 40%. Seen him in clinic for 2 times at 2 weeks and 4 weeks. He's back to normal activities and back to normal work. His ejection fraction 35 with akinetic anterior and apical walls. So the question is, what I have done, was it within the guidelines or I moved beyond the guidelines? Is there any evidence of late mechanical support in cardiogenic shock? No data, and there will be no data. There will be no data, as no more studies will be done on anti-aortic balloon pump. The available data, in fact, is against that, because it might reach the class 3 to put a balloon pump in these patients, because we don't have data in the acute setting. How about in the chronic setting? Guidelines in the ACC and ESC, they don't mention now intra-aortic balloon pump. They are talking about impellers and microaxial flow machines. In fact, you can appreciate that at the end, that if intra-aortic balloon pump to be inserted, it's not just the class 2B, but it's also for mechanical complication, not any more than that.
Almost finished.
Okay, I'm done. So again, balloon pumps are not anymore in the guidelines, unfortunately. And I'm going to, these are more trials are being done, but none of them on intra-aortic balloon pump. Everybody depending on the culprit shock MI when they put balloon pumps, and patients did not get any benefit. So during my training, we thought that the guidelines will be made by super rich people on a glass of wine, sitting together and putting the guidelines for the other rich people. Then people did not like that. So we thought that the guidelines may be made by the rich for the rich people, but they did not like that either. So finally we said guidelines are made for the rich. Okay. I think myself that intra-aortic balloon pump is not being mentioned in many of the updated guidelines, yet it might be the only device available in many financially challenged medical centers, as the one I work in, and yet it might be the only hope for the hopeless. Again, all of us, I'm pretty sure all of us, everyone who is practicing interventional cardiology can mention many examples where that intra-aortic balloon pump made that hero of life, that favored the life of his patient, of course, after God wills. My take-home message is, if you are practicing like me in financially challenged medical center or centers, keep intra-aortic balloon pump on the shelf, because on a full moon night, it might be the only hope you have left for the hopeless. Until guidelines are made for the commons, for all of us, I thank you.
Thank you.
Let's open the floor for discussions. Any questions?
May
Yes,
I-
Dr.
may I-
أيمن. أعطوه ميكروفون لدكتور
هاي
أيمن.
الميكروفون هناك وراء.
ماشي. بس احكي عليه.
We all use the intra-aortic balloon pump, and I think if the shock severity is not that bad, intra-aortic balloon pump will have a place. And if the shock has any mechanical issues like severe MR, VSD, yes, intra-aortic balloon pump does help. Thank you.
Yeah, I agree with you. I can't agree more. It's the unfortunate thing. They are not mentioned anymore. And I was discussing, Ahmed will have a comment now. Intra-aortic balloon pump is falling out of favor because the guidelines are not made for every one of us. They are made for people who can afford expensive devices. Fadra.
Exactly. Which our experience in low-income countries, this is the only way that we have. But what if your patient problem is the increasing of MR? You have a patient with an MR, maybe this is the problem, and when you put the balloon, you deload the LV and the patient got improved. So sometimes you need to go beyond the guidelines.
I agree.
But if you're gonna want to use it, as you mentioned, you try to use it as early as possible. Most of those patients do not include in the trial because they are in severe shock status. The lactate is extremely high, above 10. The patient is multi-organ dysfunction. If you're gonna use it in the sweet point. It will make a difference in most of those patients, especially if you have something mechanical. And sometimes we fail to diagnose and appreciate those patients who are mechanical. And the consensus, you still use those support, even if you don't use it in the guideline as early as possible. It may help those patients. And always the guidelines, there is something beyond the guidelines most of the time. But what if you are in the middle of a STEMI and the non-culprit vessel have a TIMI 2 flow or TIMI 1 flow? What are you gonna do? And the patient is shocked, are you gonna vascular open it or are you gonna leave it? If it is like a simple procedure, you put a stent in 3 seconds, are you going to do it or not? And sometimes I believe you can go beyond the guidelines. My second question is to Dr. Nizar. Always the stenting, I will appreciate and I will stent this patient. The stenting in the spontaneous coronary artery dissection, if you have a major vessel, if you have a proximal LED, you go. But with my question, are you be eager to manipulate this patient again? To me, I will leave this patient for at least 1.5 months before I attempt to do anything. And I was to do anything to leave him to heal. Thank you.
Well, I can't agree more with you about beyond the guidelines. Just we don't need to make it a habit for our junior colleagues to start going beyond the guidelines without knowing the guidelines. So, yeah, go ahead.
Yeah. I think you could appreciate that even in the middle of that procedure, we were thinking of leaving this. We've restored flow, we've got TIMI 3, and we'll reassess her at a later stage. But when you look at this significant hematoma, which was compressing the proximal LAD, and it already occluded it, so we thought we had to do that. For the later on, the question was about the diagonal, the left circumflex, and we asked for, she was still complaining of chest pains, by the way. And she was referred for, we referred her, we thought we were going to do an IVUS to assess the extent of the hematoma. And she was transferred to the Nizar hospital where Dr. Yunus done the IVUS for her. So part of it was planned, part of it was because she was still complaining. So that's why we got it done a bit earlier than what we wanted to.
Question
I have a
to
question, Dr. Aqel, for you. First, in your first case, which you presented, after you open the right coronary artery, still she has chest pain. But I noticed STEMI flow 2 was. So it might explain the persistence of chest pain. Second, in your second case, after you stented the proximal and mid LAD, before the bifurcation, there was significant stenosis in LA view, left anterior oblique view.
Yeah.
So I guess you should put stent at that time. You might save another infarction because she came back again with infarction.
Yeah.
In the same vessel because of sluggish flow, I guess.
Yeah.
That's why you get thrombosis.
Thank you, Dr. Zakaria. If you allow me, it was done by one of our senior colleagues I work with. And I think at that time the patient was really unstable with too much jumping on the cat table with DC shocks. So the main target was at that point is just to keep him alive, stabilize him a little. He was really going away. This is the reason why they did not stent the middle and that area at the diagonal that you saw, which I agree with you fully. I might have stented it, I don't know. But at that time, it was a saving of life thing that was done. Really, the first case, the TIMI 3 in the RCA was a 3 minus. Yes, I agree, you might explain, but the question is, what should you do? This is your case on the table. This is the best I can do for the right. The patient's still shocky. He's more than 24 hours, and I know the RCA would not help that much. Evidenced by the echo was showing anterior hypokinesis, which was done later. So I agree with you.
If you allow me, please,
Yes,
Dr.
please.
Sharia, a question to Dr. Mahmoud regarding complete revascularization. I think the most important element here is the stability of the patient. And stability of the patient does not mean only lack of cardiogenic shock, because the history, the legend, and the comorbidity play a role when you are deciding to do complete revascularization. It's not only lack of cardiogenic shock. What do you think?
But we are fixing the same vessel. We are not jumping to another vessel. You know what I mean? And we are talking about the same vessel to fix it completely. And we fix the proximal and mid portion, and before the first diagonal we left it. We should complete.
So my question to Dr. Mahmoud regarding his lecture, first one.
Okay.
Complete revascularization. Shall I repeat?
Okay. There is general rule. There is no size fits for all. Sometimes you have to select your patients. I get in my presentation, there was 3 presentations. One of those presentations, no reflow phenomena. If you have no reflow phenomena, the patients got 12 milligram of adenosine, a lot of contrast. Those patients, you don't have to go for immediately to revasculate other vessels.
Okay.
Even, we are not talking about cardiogenic shock. This is case number 1. Then the other case, the patient who came with hemoglobin 8 and creatinine 1.9. Does it make sense to open up the whole facade at the same time? This is staged. Yeah, definitely there is some selections, depends on the patient. So general rule, there is no fit size for all, so you have to tell.
دكتور رايد يعطيك العافيه. البرزنتيشن نايس، بس اخر كيس شوي انا ما فهمت فيها. الاي سي جي الاول تبعك بين انه في عندك اس تي elevation بالانفيريور ليدز. Then the other one showed inferior anterior lateral. For me, I think انه ال LED being closed for several days. I think the culprit lesion is the RCA.
Could be.
If you look to the RCA, you see even the retrograde filling of the LED a little bit. I think what happened at that moment, it be included. هاي شغلة ثانية فيما يتعلق بالسبورت اللي circulatory support. I think بالكارديوجينيك شوك احنا كلنا بنعرف انه there is no role. في 27/3 طلعت اللي هي الترايل the use of circulatory support in patient with low ejection fraction, okay, and left main disease or multivessel disease. It was negative. يعني احنا مش انه we are sorry we don't have impella. Impella does not work. I think. يعني في special cases it may work.
Well, you know, I think I'm very happy sometimes that I work with in environments that I have only one option, because that keeps me without any feeling of guilt. So I do what I can, but if I have an impella and a microaxial flow device and intra-aortic balloon pump, I'll be scratching my brains and which one works better? But I have intra-aortic balloon pump, I have a dying patient, I have nothing more to lose. I'm going to try it.
Yes. دكتور نزار، سؤال لك. يعني أنا مستغرب أنت بتطلع على LED من هالشكل almost occluded, very faint flow بال LED, troponin very slightly elevated. هل هذا بيخليك إذا أنت بتيجي بتقارن تطلع على هالصورة هاي؟ وإحنا بنعرف recommendation for SCAD, especially in young women after birth, it's better to do conservative treatment for such a patient. يعني هاي تخيل 20 years عندها استنتاج for life. انت يعني حكمنا عليها بالadaptive treatment او single treatment at least for life. 1 year for that. اثنين انت بتشوف الدايسكشن still there يعني
صحيح.
I don't know يعني انا هذا شوي تروبونين كمان.
Okay, her troponin went up subsequently went up to 55 or something like this next day. The treatment there is a difference between guidelines and specific cases. When you talk about guidelines for SCAD medical management, when you have a TIMI3 flow in the arteries, when you have an occluded LAD, there is no guidelines. You have an occluded LAD, whether this is SCAD, this is whatever the cause is, you have an occluded LAD, you need to intervene to open it, to try to save the myocardium. So the guidelines is there for patients with a TIMI3 flow and spontaneous coronary artery dissection, where you get a little bit of a leak and a little bit of a hematoma. In this case, I don't think that anyone would tell you, leave this artery for medical treatment. It's an occluded proximal LAD. So I have no hesitation in opening it up. The question was, do I put stents or do I come back to it later on? And with the images that we've seen, with this severe hematoma, which we've seen on the IVUS, which was done 2 weeks later, that there was still severe residual hematoma on the proximal LAD, we had to stent that.
دكتور محمود زريق، السؤال إلك. سؤالي انه احنا مزبوط في جايد لاينز وترايلز، في لاند مارك ترايلز اللي هي احنا بنعتمد عليها، لانه باعتمادك عليها لا شك انه انت بتكون اتليست كفرد، تحس حالك انه انت يو ار فير انف مقابل المريض. بس كثير مرضى احنا بنحاول نعمل لهم ستيجد بي سي اي، اوكي ستيبل بيشنت، وي لوك فور بصراحه انه عندك هاي ديجري اوف ستينوسيس، بس at the same time انت بتقول هذا patient presented with acute myocardial infarction. في عندك neurohormonal response اللي هاي بتعمل كثير مرات lesions more significant, looks more significant, and really it's not significant. يعني ياما احنا شفنا مرضى ومش عدد قليل لما نجيبه للستيج بتقول له عندك ستيج لل LED، بتجيبه بعد اسبوع اسبوعين انت بتعمل انجيوجرام تضحك على حالك، بتقول معقولي انا جبته هذا للستيج؟ بقول لك يا زلمه انت اللي طلبته. ترجع على هذا بتلاقي ورا يمين انه في عندنا نيورو هرمونال ريسبونس الموجوده، we should consider it. اثنين، I don't think just stents is the treatment. Medication is very important. كثير ناس بصيروا عندهم من الايفوس ستادي which been 20 years old، الايفوس ستادي اللي حكت انه في عندك ريجريشن في الاثيروما when you are decreasing the level of LDL less than 70 mg per deciliter. يعني انا بعتقد انه مش لازم نكون ستيكي كثير، ممكن الدراسات اغلبها انعملت في اوروبا مش عندنا، يعني احنا الشعب مش ملتزم. يعني انت بتحكي، بس انا متاسف بدي اوصل الجمله، يعني احنا التريتمنت عندنا للسكري على سبيل المثال بتقول بنزل حسب الجايد لاينز وحسب الكتب 0.8 مثلا بيرسنت. عندنا عند العرب لا بنزل اكثر. ليه؟ لانه احنا عالم ما بنلتزم لا في نظام غذائي ولا في تغيير حياتنا. ففي فرق بيننا وبين الاوروبيين انا اعتقد في كثير شغلات، وهذا بينطبق على الكارديولوجي وعلى الفاسكولار سيستم، مايكرو فاسكولار كومبليكيشنز. اعتقد احنا مش مثل الاوروبيين.
مش عارف مشكله في السماعات.
دكتور وفاء لاست كويشن. دكتور وفاء لاست كويشن.
وانا مبسوط لهذا الحكي لانه هذا الحكي ممتاز. راح يكون
أنا دقيقة بس.
أيوة وفاء.
يعطيكم العافية. أنا دكتورة وفاء, consultant internist. My question to Dr. Nizar about the case that he presented, which was very interesting. The patient who has been 22 years old, we didn't dig out in the history about the family history of coronary artery disease, hyperlipidemias and others. But very importantly that she had the pain and the presentation following delivery. And the lesions are multiple. Did you consider vasculitis, and especially when she had recurrent thrombosis, although it's arterial rather than venous, but regarding the pulmonary embolism and antiphospholipids, for example, she needs to be on anticoagulants rather than dual antiplatelets, and planning for further and future pregnancies and deliveries. This is very important for the planning of the patient and also for our knowledge, let's say.
Yeah, thank you for the question. I think with spontaneous coronary artery dissection, this is an entity which we see with ladies. Usually it occurs within the first week post-delivery. And normally it's because of the high estrogen and progesterone, which increases the permeability of the arteries in these patients. And then you won't get the normal dissection, rather than you'll get a little bit small dissection and then you'll get a hematoma. It wasn't a multi-vessel disease, so to make me suspect vasculitis. Normally with vasculitis you will see disease in the LAD, the CIRC and the RCA. And from the angiography here, the RCA was completely normal, the left circumflex was completely normal. So this was a specific disease that occurred in the LAD itself and the diagonal subsequently. So, and after, a large number of patients that we've seen, we've never seen a woman who's 20 years of age who would present with an acute MI because of familial, like she's a non-smoker, she had no significant family history of ischemic heart disease, and I don't think this is a vasculitic thing. So after putting 2 stents for her, I think she needs to be on dual antiplatelet therapy rather than anticoagulation. And of course, we'll be aiming at re-imaging her maybe after a few months to reassess the situation again.
Thank you, Doctor. Let's move to next.
الله يعطيكم العافية.